Okay, all right. Good evening, guys. So based on your votes in the last week or so we are starting with another PYQ. So, but we're gonna choose 50 particular questions which are like more difficult and kind of more application oriented. So this week we are having GMCH 2023 question paper. Okay. So what we'll do is we'll go through each question, we'll find out answers for it, and then we'll try to explain why this is the answer, why it's not the answer, and kind of go in depth into that particular topic. Not too in depth as in the whole unit, but maybe try to explain it in a bit more detail so that you can cover that topic as well. Okay. So we have about 50 questions. Just confirm if you can see the screen where you see the Word document with the questions that are written there. Is it visible? Can you just confirm that? Is it seen? You can put in the chat also.
Yes, sir, it's visible.
Yeah, okay. So please make use of the chat if you want to ask questions. So note down questions that you want some more details on. Okay. So chat is working unlike last time. So please make use of the chat. Okay. All right. So this is from GMCH 2023 paper. I actually really appreciate this paper more than IBHASCA paper because there are a lot of application oriented questions. Right. So in IBHAS, it was just based on memory. What is this dash? And then we have options. It was too direct. It was too simplified, almost like UG level. So has anyone wrote this exam in 2023? GMCH. So any idea what the cutoff was in 2023? Could you just inform that? If you can just raise your hand also, it's fine. You can tell me like if anyone has attempted this particular question paper before in 2023. No? Hey, you guys are being very ideal students. Okay, fine. So we'll start with the question. So the first one is, so you're hypothesizing that pediatric cases of autism, so in your clinic or somewhere, are because of some sort of a maternal vaccination. The mother had got a vaccination. Okay. So the research design will be what? So that is the basic question here. So what sort of a research design is most appropriate here? Okay. So you can put A, B, C, D in the chat so that you can simultaneously answer and mark. And I'll also tell you what is the most correct option here. Okay. So the design of your study, which is ethically acceptable and also provides information in a reasonable time, is dash or A, B, C, D. I'll just like wait for you guys to give the answer first, and then I'll tell you. Okay, one person said case control, yes. Anything else? Nobody has any other options. Okay, people have said A, which is prospective cohort. A. Okay. So people saying A, I would say it's actually no, it's actually unethical, right? So if you suspect that vaccination can cause autism, I don't think so you're allowed to do it prospectively by giving, you know, vaccination and then studying. I mean, you can study prospectively, but people have to go in and take it. So the most ethical way, because they said it's ethically acceptable, the most ethical way would be case control. So case control is a retrospective study. Retrospective in the sense it goes back and identifies whether a person had exposure or not. So cohort is the opposite of it. It's prospective. So in cohort, so exposure, either yes or no. Okay. And then later in time, you see whether people are getting the disease, yes or no, as in do they become cases or are they controls? Cases basically mean they obtain the disease or not. Okay. So you start with dividing the exposure. You start with seeing whether a person has been exposed or not in prospective cohort study. Okay. But in case control, you start with seeing who has the disease and who does not have the disease. Okay, so then you go back in time and then see who were exposed and who were not exposed. Okay, so that is the case control design. Here you already know people have autism or not, as in the child has autism or not, and then you go back in time, and as in you don't actually go back in time, you ask the mother whether they have taken this particular vaccine or not. Okay, it's not a descriptive study, it's not randomized control trial. Okay, so because in randomized control trial it is not ethically acceptable to give something that can cause harm, right? So those have said B, congratulations, so you are on spot. Fine. Any other doubts in this question? Why this is so, why this is not so? You can use the chat. Feel free to use the chat. No? Okay. All right. So moving on to the second question. So the term sensitivity used in statistics while measuring instruments is defined as dash A, B, C, or D. Go ahead. I'm looking at the chat, so we'll wait for a few minutes. Okay, so one person said to identify a case correctly. Okay. Any other? You can just say A, B, or C, or D. That's also fine. Any other takers on answering question 2? No? Okay. So I think everyone will go with A, correct? Yeah. So sensitivity is basically the extent to which one new measuring tool. Okay. So you're developing a new measuring tool, and there is some other tool. Let's consider the gold standard. Okay. So compared to the gold standard, is your measuring tool getting it right? In the sense that, is it identifying a person with a disorder correctly? So that will be sensitivity. Okay. So the opposite of sensitivity, or not exactly opposite, so the other measure which is related to it is specificity. Okay. So that would be the ability to identify those without the disease. So in the gold standard instrument, so there are certain people, 80 out of 20, who do not have the disease. So to the ability of your new tool to identify those 80 people as not having a disease will be specificity, which is option B. So option C and D are also similar here. So they are basically true positives, true positives and false positives. Okay. So, but the difference here is that this is for a new tool, right? So this is for a pre-existing tool in terms of its correctness. Okay. So you use a new tool here, and positive and predictive values are usually used for an existing tool to see its accuracy, but you may not know whether they actually have or do not have the disease. So that is something you do later. But in this case, you already know based on a gold standard, this person has a disease, whether this tool is identifying it correctly or not. So that is the difference. So A is the correct answer here. Okay. Any questions? Why this is so? No. Okay. Right. So we'll move on. So third one from the list below, the highest level of evidence in scientific literature is generated by A, expert committee recommendations, B, observational studies, C, randomized controlled trials, D, systemic review of correlation studies. So what would be the right answer? D. Okay. So I also agree with you, but this set of paper does also have an answer key which says A, but I would actually disagree with it. Okay. So the answer key says A, but the right one would be D. Okay. So the reason, I'm not sure why they say it's A. Just because experts say it doesn't mean it's correct. True, right? So experts can be wrong also. So experts do disagree between themselves even on basic things like definitions. So it cannot be A. Yeah. So observational studies do not have the highest level of evidence. So even randomized control studies do not have highest level of evidence. So it will be systematic review, or you could say meta-analysis. So I don't know why they put systematic review here, because systematic review is more of a qualitative data collection. So a better thing would have been meta-analysis, but still you can do systematic review and then find, okay, this is what most of the studies are saying. Okay, so maybe that is one of the reasons they said it is not B, but you can do systematic review for a correlation set of correlation studies too, and then say this is what is related and this is the overall seeming evidence. So I would say it's still D. So sometimes there are options which are like this, and there may be differences between what is actually true and what the answer key says. Okay, so any other questions here in this case? This was GMCH 2023. Okay. Is that the question? Any other questions apart from which year is it? Why D is correct? So the reason why D would be more correct is because it's systematic review, or even if you do a meta-analysis, it pulls a lot of data from different studies and then finds what is the existing pattern between several set of studies. But these are all basically individual studies. So we understand that expert committee can also be very qualified, but not necessarily true in terms of having highest level of evidence. So this is definitely not correct from my perspective. Okay. So anyway, so moving on, fourth question. Okay, mean temperature of 25 patients is 100 degree Fahrenheit, and standard deviation is 0.5. So what is the standard error? So you have N, and you have mean also. What's happening? Just 1 second. You have mean also, which is 100 degree Fahrenheit, and you have SD, okay, which is 0.5. So what would be standard error here? Any takers? Anyone wants to go with the question? You actually do not need this to answer. That will be one hint. You actually do not need the mean to get answer. What? I'm not sure why suddenly chat stopped. Just a second. Okay, so I'll go on until people are not able to use the chat. So what you have to do is you have to basically divide the standard deviation by square root of n. So that will be 0.5 by square root of n is 25 by square root is 5. So we'll get 0.1. Okay, so that'll be option C here. Okay, so this is how you calculate for standard error when you already have standard deviation and also the number of patients or the total number. Okay, I'll just check. The chat is on. So you guys try using the chat. Okay, so the answer is C. Okay, so it will be 0.1. Okay, so moving on to the next one. An accident victim loses his right hand and this results in him being unemployed. So situation is best explained by which of the following terms? Is it handicap? Is it disability? Is it impairment? Or is it illness? So I've made the chat on for a longer duration, so you can try putting the answer in the chat. So would you call it a handicap, disability, impairment, or is it called illness? Okay, so in the meantime, you're putting the answers. Illness is a subjective experience of being unwell. Okay, so of course it would meet the criteria here, but what would be much more better is impairment, because he has lost a part of his arm. That is a physical impairment. This is also not the right answer. Disability would be when he's not able to perform particular functions that he earlier used to do. Okay, so he has lost his right arm and is not able to perform functions. But being unemployed is not just about certain functions. It's also related to being employed in a society, right? So handicap is the highest form of, not being able to do things. In terms of handicap is about not being able to access a lot of areas, not being able to access and participate in certain parts of society. So handicap would be the most correct answer here. Okay. So to recap, illness is a subjective form of feeling unwell, discomfort, distress. Impairment is having a physical impairment. So physically the person did lose his hand, that does count. Disability means because of that impairment, he's not able to perform certain functions. These are very specific functions. Okay, so unemployment is not a very specific function. So if he's not able to walk because of disability, not because able to see things, that will be very specific. So disability can be mentioned here, but the person is being unemployed, which is the key word here. So that would be a handicap. He's not able to work further. Okay, so yeah, if any of you have questions, do go ahead. Yes, Yukta.
Handicap, this word, I heard that we don't use this word anymore. So is it like
So
that we use it or we don't?
So the RCA actually has changed it. So in 1992, you have the RCA Act, right? So that is where the words handicap, all those things were there. So those were like revised and more appropriate terms were used in the RCA 2000 Act. So that you are correct. So, but based on the levels, so handicap means a person is not able to access various social aspects, okay, and his environment. So the access is restricted. So in this question, it would be handicap, but you're also correct in that it's considered kind of like a derogatory term, or it's kind of more off-putting for the person to get this label. So it has been changed in RCA 2000 Act, but it was there in 1992 Act. Does it make sense?
Yeah, okay, okay.
Right. So we'll move on to the next one. So in psychological rehabilitation, the main aim is to do dash. So is it A, restore social relations, B, provide financial support, C, personal confidence, restore capacity to earn a livelihood? So what would be psychological rehabilitation? So D would be a likely option. So actually the answer key says it's C, but I would say anything apart from B is a possible answer, right? So because we do not give them financial support alone, even though it's part of the rehabilitation. When a person has disability, financial supports are given, but it is not the main aim. So B is definitely not the right answer. Okay, so restoring social relations, yes, it is a part of rehabilitation. Restoring personal confidence is also part of rehabilitation in terms of self-esteem and things like that. And D is not necessarily always true, but we also work on it as a part of vocational training. So I would say it's either A or C. D is also likely to be correct, but if you consider the main aim, it should be A or C. Okay, so the answer key goes with C, but I would say even A kind of works. So this is another sort of a question where you have a very ambiguous set of options. The options like several things can be correct. Okay, so even though C is likely to be true, A is also equally likely to be true. I don't see a hierarchy here in terms of C being even more important than A. But D is also true, but it is less likely to be applicable everywhere. For example, you have a housewife, okay, or someone who is not employed or is a student. So if they have a illness and you are rehabilitating them, we need not necessarily always work on vocational rehabilitation immediately. That's also a part of rehabilitation. So I wouldn't say it's the main thing. B is definitely not there. So it's either A or C. Okay. But to consider C more than A, I don't know. So I don't think so. It's like that. But the answer key goes with C. Okay. So any questions, anything you guys found you know, not right? This is not supposed to be like this. Yeah, go on.
If it only says in rehabilitation, then the answer would be D, right? But when it comes to psychological rehabilitation, then it becomes A and C.
No, not necessarily like that. Psychological rehabilitation is especially for our psychiatric conditions, right? So when we talk about rehabilitation, the person should be a part of a community, restore functions, and also restore his self-esteem and things like that. So social relations are also included there. But this is very, let's say, context specific. Okay, if the person was working earlier, then we would be working on this part, right? So it's not always true. So this is typically considered part of vocational rehabilitation, which is also under psychological rehabilitation. So rehabilitation in general overall would include the person being getting back into the community in all aspects, in terms of social, in terms of financial, in terms of being an active part and everything, and also feeling personally meaningful, and include the confidence part also. So in that way, financial support is not the main criteria. This is also kind of context specific. So C and A again. So hope that answers your doubt.
Right.
Yeah, vocational rehab would be considered a part of psychiatric rehab. It's a part of it. So rehab itself means them being part of community that includes social. Okay. So since it's more context specific, that's why I said it's a part of psychiatric rehabilitation or psychological rehabilitation. Fine. Okay. So moving on, fluctuation of a disease trend that occurs over a long period of time is defined by A, seasonal trend, cyclic trend, secular trend, a propagated trend. So this will be about epidemiology. So understand, many of you may not have had this in your master's levels. That's okay. You can take a guess. We'll see. So I feel like the GMCH paper is more about what you may learn after you get into MPhil rather than just the master's level. So it's slightly more tougher than most other papers. And also it's kind of more application oriented, which is good. So instead of just, memorizing and then saying it out, so this would be much better. Maybe if you practice this, those 5 questions that are usually present as higher order thinking skills may be covered here also. Anyway, so secular trend. Okay, any other takers? Seasonal trend. Okay, not really. So here the explanation is, or the item is, that fluctuation of disease trend occurs over a long period of time. Okay, so it is something like a natural trend. Natural trend as in over a longer period of time, it's changing. So seasonal trend is something that you'd expect every season to occur. Okay, even though seasons kind of do qualify for long period, it's not what it is meant here. So they're talking about years. They've definitely put bracket years so that you don't get confused and say seasonal. Okay, so it's not seasonal. Cyclic means it keeps happening over and over. There's an increase and decrease in this particular cycles of sort. So it is not cyclic trend. Secular trend is the right answer. Okay. So propagated trend would mean for any sudden outburst of diseases, like COVID could be an example. Okay. So ups and downs in that. So that's a propagated trend where the wave comes up. So things like that. So secular trend is the right answer here. Okay. Okay. So it is C. Okay. So seasonal trend, though, you can already guess it's based on season. Okay. So some disorders like seasonal affective disorders do increase in certain seasons, right? So that would indicate a seasonal trend. So we're talking about something that changes over a long period of time, like years. That they're talking about things like prevalence, incidence, and things like that. All right. So moving on to the next question. Confounding bias in a case control study can be removed by A, B, C, or D. So confounding variable or a confounding bias where you do not know what is actually there, it is an extraneous variable. So in a case control study, so you already know in case control, you go with cases or control, and then retrospectively you see how many of them were exposed or not exposed. So here, let's say there is some sort of a confounding variable at play. What is the way to remove it? So I hope you guys understand what is case control, because this is again an epidemiological term which you may not have come across. Okay, so people are saying A. Okay, so A is the correct answer, because in the case and control, the difference between a case and a control need not be different from the very start. If there are some factors which differentiate case and control from the very start, for example, a lot of people in the cases have higher IQ and a lot of people in the control have lower IQ. So that itself is another confounding variable. So you'll have to match them so that both of them kind of are equal in terms of the IQ. I'm just taking IQ as just a random example. Okay. So it need not necessarily be that only. So you'll have to match them so that both case and control, before you start collecting retrospective information, are matched. Purposive sampling does not make any sense. You are going to get like samples based on one particular hospital. So just because you perform it in several hospitals, you may increase generalizability, but it will not, reduce confounding bias. And you cannot randomly assign also, like in RCT, which is not possible, right? So then matching becomes the only way. Accurate recall is something out of control. If they cannot recall, how will they make it accurately? So they may have some recall biases that is inbuilt in retrospective studies. You cannot change that, right? So matching becomes the correct answer. Option D is performing in different hospitals. Just increases the generalizability of the study. In a way, it can make it a bit more random, but if you do have existing difference between case and control before you start the retrospective data collection, that itself can be a variable of making it different, making the results different. Okay, so yeah. So moving on, the ninth question. A study on experience of 100 slum-dwelling postpartum women in the first 4 weeks after delivery of live-born baby by use of a questionnaire is an example of what study design? So they have given a very detailed explanation. So it could be very distracting. So they're studying the experiences of 100 people, postpartum women, after 4 weeks of delivering a baby. Okay, they use a questionnaire for that purpose. Okay, so what sort of a study is this? Okay, so tell me one thing: is it prospective or retrospective?
It is retrospective, I guess.
How retrospective means going back in time, right?
Okay.
So you identified people who have given birth, and 4 weeks later, you talk about their experience.
So the
Right?
experience is has happened in the past, right?
Sorry? No. So what they're saying is you're studying the experiences of so many people. Okay. So within the first 4 weeks of delivery, so what you will do is you'll identify a certain number of people who have given birth. Okay. And then what you do is you go ahead and then collect information for at least 4 weeks later, minimum of 4 weeks. because 4 weeks have to elapse, right? So it is almost like you letting the 4 weeks elapse, waiting for it to end, and then later, at a later point of time, you're going and interviewing them. So first you have to identify. So they have not given a lot of details. That is also one drawback of this question. So if they are saying you go to a slum and identify who are postpartum and at least 4 weeks longer, that becomes a criteria. That would be kind of retrospective. But what they intend to mean here is that you identify 100 people who have given birth, and in 4 weeks of time, you go and like administer a questionnaire. Because you're administering a questionnaire, I would not call it qualitative, because questionnaires can be qualitative too, right? If you're using kind of an interview like schedule, but they have not clearly mentioned it. So we cannot exactly say it's qualitative. Questionnaire most likely is kind of like a quantitative data collection. It can be qualitative too. You're not wrong if you say qualitative. Definitely it's not an interventional study. Definitely it's not an experimental study. So this is a bit questionable. It's more likely to be a cohort, given the identifying 100 people first, waiting for 4 weeks, okay, and then talking about their experience. So this is more likely to be a cohort. Qualitative is a question. So you can possibly rule it out using the word questionnaire, because questionnaires most likely can be a quantitative way of data collection. What do you mean due to similar experiences? I didn't get your question. Similarity of experience doesn't make sense. That is what you're studying. So cohort is basically you identify exposure right from start. Okay, so here exposure is just a second. So in cohort, you identify exposure versus non-exposed group. Okay, so this would be people who have given birth and people who have not. So then over time, after 4 weeks, we see who may have developed depression or who may have developed some other, disorder associated with it, any other illness, any other social difficulty, things like that. Okay, so this is kind of a cohort study. Good that they have not given any further confusing options, such as if they had given case control, that would definitely made it even more confusing, because they clearly have not said you're going retrospectively or prospectively, but you'll have to assume that here. Okay, because they said in the first weeks after delivery. So that's the assumption I would go with. And sorry, it's not qualitative, it's cohort. Okay. So possibly they wish to identify the incidence of a disorder like postpartum depression or something like that. Okay, that is what they want to know. So based on the experiences, so basically experiences, what do they mean? So what have they been up to and what was happening with them? So you collected using a questionnaire. That's a bad idea for a tool like data collection tool in this case. But anyway, it's kind of a cohort study. Hope that clarifies the thing. Okay, anyway, so let's not waste so much time on one question. So next one is, what part of the brain is involved in speech production? Broca's area. It's a straightforward, simple. Okay. So particularly left side is where you identify the Broca's area. So there's a parallel right side of Broca's area, which is involved in speech production, but not for the content of speech, but for prosody. So maintaining prosody is to do with the right side of the Broca's area, the parallel, the symmetric side. Okay. Wernicke's area is in the temporal lobe. Okay, this is in the frontal lobe. This is something you have to remember. Wernicke's area is in the temporal lobe. It is involved in speech processing. So if they had put processing here, you should have said Wernicke's, right? And similarly, Wernicke's is also kind of lateralized. Left side is for understanding the content of speech. Right side is for understanding the prosody of speech, the intonations, the emphasis that people give. If you're not able to hear the intonations that they're giving, possibly the right side of Wernicke's is affected. So this is likely to be a connecting tract between the, especially around the, what do you call it, ventricles. Okay, so Cillian fissure is the lateral fissure. So even though Broca's around areas kind of around the Cillian fissure, it's not the exact area. So it's Broca's area. Okay, so the lateralization is also something you can remember. That can also be a possible question. If it was speech processing, it would have been Wernicke's area. That distinction though you have to have. Okay, right. Moving on. Which is the correct term in substance use disorder regarding psychological dependence? Which term is for psychological dependence? Okay, people say tolerance. What else? Anything else? Craving. I think you guys will be faster if you say options. You can just put the question number and option. That will be much more easier for you rather than typing the whole word. Just a suggestion from my side. Anyway, so we'll start finding correct answer. Kindling has actually nothing to do with here. Kindling is basically a way of saying neurons that fire together wire together. Okay, so it's kind of like association. Let's ignore that. Tolerance is when you have to have more and more levels of alcohol. Let's say it was 2 units that a person was drinking. Now that doesn't bring him much pleasure or something. So this is more physical rather than a psychological dependence. So withdrawal and tolerance are physical dependence symptoms. Okay, so that means the person has been using alcohol and has become physically dependent. So when he stops, physically he has these difficulties, which is withdrawal symptoms. And because of his constant use, he's physically not able to feel that pleasure. So these are physical. So craving would be the correct answer here. Not this or not this. So craving means the person psychologically wants it for the rewards that the alcohol gives him. Okay, so that would be a term regarding psychological dependence. So psychological would be your keyword here. So dependence is characterized by craving, withdrawal, and tolerance, but psychological dependence per se is B, craving. Okay. Right. The process of learning involving trial and error was based on the work of A, B, C, or D. Bloom's taxonomy is not to do with trial and error, so we'll go ahead and remove that. Pavlov is about classical conditioning. There's not much of learning something by trial and error there. Okay. Skinner did kind of include trial and error, but it is Thorndike in his experiments with cats and the escape cage thing. So once they press a lever and identify escape, so he literally like tried to identify how many trials it took for them to learn that. So that is the trial and error. So Skinner, even though he had a button pressing for pigeons, so even though they kind of initially trial and error wise they made it, he was not explicitly stopping with that. So he went on further to shape their behavior, discriminate the buttons, colors, and lights and things like that. So even though trial and error is part of Skinner's experiments, it's not exactly that Skinner did. So it is Thorndike. Okay.
Tolman also had trial and error learning, right?
Tolman had, wait, was it trial and error learning or latent learning? Tolman had latent learning, right?
Yes, it was.
Latent. Okay, cool. So it is Thorndike who literally had cats in their cages, and you would have a lever for opening the cage. So that cats had to do and press. So the more number of trials the cats were in a cage, the more faster they came out. So that was learned by trial and error. That is what he identified. Okay. And that was more to do with insight. But given these options, let's stick to these options. So otherwise, there are a lot of people who did study on trial and error. So moving on, in a picture of a room, two lines have a similar length. Okay, but in reality, they have a similar length. Okay, phrasing is a bit awkward, but appear to have different lengths to the observer. So what is this phenomenon called? It's not a hallucination, so I'm going ahead and removing it for ease. Okay. In a room, what illusion do you usually see? I also give you one more hint. Any cultures which do not have square rectangle shaped rooms, they are less likely to see this illusion. It is the Mueller-Lyer illusion, because in a house, okay, so if it is like this, okay, so anything with a open arrow is more likely to be seen as bigger than anything with a closed arrow. Okay, so that is the Mueller-Lyer illusion. So because of perspective, this may seem bigger, but if you were to have two lines which are closer to each other, right, so one with the open arrow is more likely to be seen as a larger one. So therefore, bigger or smaller depending on the arrowheads that surround them. So it's Mueller-Lyer one. Anyway, so moving on, type A and B behavior patterns can be measured by which of these measures? So type A and B are personality types given by so a few cardiologists. I'm not able to get the name. Wait. Okay, so they were not given by a psychologist. So what is the answer here? What sort of a measure would be best to determine type A or B? It's been a long time, so I'm also forgetting the names of authors. A. So it is A, because other things not necessarily identify type A and B behavior. So they are more about the physiological arousal. Even if you can theorize and say type B people are more laid back, so galvanic response could be low. So even if it does make sense hypothetically or logically, GSR is more likely to be more varied. Okay, so it is not more specific. Sorry, it is specific, and it is not more generalized. So nothing to do with the personality itself. Even though you can see some differences, that would not be there. So it's actually Jenkins activity survey that determines whether a person has type A or type B set of behavior patterns. So CT of the brain, I'm not sure if it's going to give any differences. RIBT does talk about, it doesn't talk about it, it does convey differences in personality. You may see it, but there is no hypothesis particularly for type A and type B behavior in RIBT manuals, not as much as I know. Okay. So it is option A. Oh, no doubts. Friedman and Rosen. Yes. So there was some man involved. I forgot about that totally. Okay, thank you for that. So yeah, next question. Vygotsky's theory of the zone of proximal development indicates children can perform at a higher level by regularly participating in competitive tests. I don't think so. We'll move to that. Support of teachers and capable peers. Support and encouragement by parents. Attending extra tuition classes on the subject. Oh my god. Fine. So it is either F or G. Okay. So even though both of them seem correct and seem very similar to the theory. Okay. So the zone of proximal development says, so this is the current zone where they are able to function. So to reach the next level of functioning, they may need some aided support, usually by elders or who have uh, who know that knowledge. Okay, so even parents can do that, but they're saying encouragement. That is not exactly what it is there. So any elder who's about actually a teacher or even peers who have developed those skills. Okay, so through interactions with them, children develop into the zone of proximal development. So this is given by Vygotsky. Okay, so the more correct option would be F. support of teachers and capable peers. Okay. All right. So even though G seems like something similar, it is kind of like just given here. I feel like some of these, even the questions are good, they are application oriented. The way they write the alternatives, they can be definitely much better. All right. So next one, speeding laws in Chandigarh are very strict. I don't know whoever in Chandigarh can confirm that. No one can drive over 50 km/h. Okay. Kamal drives his car so that the speed never exceeds 50 km/h. So he never gets a speeding ticket. So what is this an example of? Is it positive reinforcement, negative reinforcement, extinction, or structured reinforcement? Okay. So even though the correct answer seems to be J here, I wouldn't say it is actually the same phenomenon here. Because what they're indicating is punishment. If you drive above 50 km/h, you will get a speeding ticket, which is typically a aversive stimulus. So what they're describing is punishment. Okay. So a lot of people do assume negative reinforcement and punishment are the same, but they are not the same. Even though we have no other better option than negative reinforcement. So the ideal thing that is described here is punishment. Okay, so if you go beyond a particular speed limit, you're going to get punished in terms of a speeding ticket. Okay, so negative reinforcement works by making the behavior more frequent, intense, or last longer by removing an existing negative aversive stimulus. Okay, for example, unless you reduce your speed less than 50, you are constantly given speeding tickets. So if the person was earlier not able to reduce less than 50 and they were constantly giving some negative reinforcement pre-existingly, so something intervention was done to take away that negative reinforcement so that he could do it. So that is negative reinforcement. For example, a person wants to go in a rain. Okay, so they cannot go because it is raining. So rain here is a pre-existing aversive stimulus. So you introduce umbrella as a way to negate this aversive stimulus. So the negative aversive stimulus is taken away. So that would be negative reinforcement. Okay. So that is not the exact phenomenon here, but by going with the options that are given, this seems to be the most closest one. But do remember, negative reinforcement and punishment are not the same. So what is described here is exactly punishment. It is not negative reinforcement, but given the lack of possible correct options, it is negative reinforcement. Okay. So it is not positive reinforcement. They are not rewarded to, exceed the speed limit. For extinction to happen, a behavior has to be there, which was undesirable, and it has to be, reduced slowly because they are not being given reward. Structured reinforcement is kind of more of a, common word. So layman terms way of things. Okay. So we'll move on to the next question. Any doubts or questions in 16? Okay. So in an EEG, the following waves are the slowest. Right? Which of the following waves is the slowest? Okay. So which of the following has the slowest frequency? If you don't know the exact wavelengths, the frequency range, that's okay. Right. So highest I would say would be gamma. So when a person is excessively anxious or over alert, the person is in a gamma level waves. Okay. So below that is beta. So when you're conscious and aware and you're able to see things when you're sensorily stimulated, so beta wave is most characteristically seen. And then lesser than that, when a person is about to go to sleep or about to fall asleep or is in a relaxed state, so it would be alpha state. Okay. So lesser than that, you have theta. So this is when the person just fell asleep. Okay. So theta waves. So then even deeper sleep, we have delta waves. So delta wave is the slowest set of waves. Yeah, O is that. All right. So moving on. So if your mother tells you you must eat your vegetables before getting ice cream, she's using dash law. So these questions are actually good. So the questions are framed really well, but it's just the options alternatives are not so great. So a lot of application oriented questions. So it's actually good to know. So it is not just from memory and describing things. So any of you answer T? Yeah, it's Premack principle. So Premack principle basically says you have to pair a low frequency behavior with a high frequency behavior for increasing the behavior of the low frequency. You have to make it contingent. So if the mother says, if you eat your vegetables, you will get an ice cream. So the person usually eats ice cream every day. Let's assume that. And then the person is mandated to eat vegetable first before eating that. So that becomes Premack principle. Okay. It's not Parkinson's law. Parkinson's law basically says whatever amount of time you take, the work becomes filled with that. So if you have 1 hour of work and you have 2 hours of time, you'll do it, stretch it across 2 hours of time. That is Parkinson's law. So Peter principle is saying it's about organization psychology, these both. So it's to do with incompetency in a way. One of it is more sarcastic sort of a thing. So Peter principle, what it says is, if a person is in an organization, they'll keep getting promoted based on their competency. So they'll anyway reach a point where they feel incompetent and stagnate there. Okay, so that is Peter's principle. So Dilbert principle is kind of like satire on it. It says that it is better to send the incompetent people into higher authorities because they will not do much damage there in terms of working with the highly technical skill based things. So it's kind of a satire on things. So anyway, the right answer is Premack principle here. Okay, so you make contingency between a low frequency behavior and a higher frequency behavior. Okay, so then the low frequency behavior also increases. So principle of reinforcement that is applied to gambling. Just a second. Okay. So principle of reinforcement that is applied in games of chance, like gambling in a casino, is which form of reinforcement? Okay. It is variable ratio because that is least likely to give extinction. So once a behavior is set, so once a behavior is learned, so for example, if you take Skinner's example, so button pressing to get reward, pellets or something like that. So initially you need more frequent fixed ratio rewards so that the person learns it. So, but they can easily reach satiety, right? So then fixed ratio should be switched to variable ratio. So every 5 or like within 5, it can be in first, second or third. So it can be varied like that. So that is the variable part. So when it is varied, you know that the reward is going to come, but you don't know when. Within this or this, we don't know. Okay. So that is how the slot machines and things like that kind of work. There is a chance to win it, but if you had won it earlier, then you may overemphasize the chance and keep putting in money. All right. There's also one more perspective, which is not part of this. So the right answer would be W. It's about people investing less money versus more money. Okay. It's like the casinos bet on that people are more short-sighted and they are more likely to bet more money, especially after winning something, rather than continuing to bet lesser and lesser to reach that chance. So for example, if there's a 1 out of 100 chance, I'm just talking about like the gambling itself, not related to the variable ratio or fixed ratio. So casinos bet on this, that whenever they get any rewards, whenever they won, so they are more likely to bet more and more money on it. So instead of betting lesser and lesser money, so 100, 1 out of 100 basically means it can happen the first time, third time, 10th time, anywhere between 100, or it may be after 100 too, as a mean, right? So if a person is betting the least amount of money, 10 rupees, 10 rupees, and 10 rupees, that is a more economical way of surely winning it 1 out of 100 times. But if they bet like more and more amount of money, so they are more short-sighted and saying, okay, this 100 can happen within the first 10 also. So I'm likely to bet that. So that is the thing casinos use and then continue to have a huge winning compared to people who may be like long-term oriented. Even then they may lose a lot, but it's kind of to do with people who are addicted to gambling versus not addicted to gambling. I'm not sure who the author was that. I'll get back on this. So moving on. So on the basis of Piaget's concept, children develop knowledge by, so they ideally develop knowledge by developing schemas, but how do they develop schemas? So these two are Vygotsky's principles. So Vygotsky basically says, so traditional and cultural influences kind of shape them. Okay, interactions with people. So they shape learning. So maturation itself does not lead to changes. It kind of helps, but Piaget didn't particularly talk about maturation itself. He talked about constructing reality out of their experiences. So by going into certain things, going under tables, so children learn and develop object permanence or other things, right? So even motor based principles, physics of motors. Anyway, so that will be A. So while swimming in the ocean, Richie got frightened by a dark shadow before he could identify it. The neurological basis of this frightening experience is explained by messages being sent from dash to dash. He saw a shadow but could not identify it even before it. He got frightened. So which explains this? So this could be one clue here, right? So they're saying he got frightened even before he could identify it. Okay, so definitely did not go into the occipitotemporal lobes, occipitotemporal connections. So even the occipital lobe takes it in, so and processes something. There also some sort of identification happens. So definitely not occipital lobe, or even to the temporal, occipital to temporal. Parietal doesn't even make sense. If it was temporal, that would have made some sense. So it is definitely not H. Okay, frontal to pituitary doesn't make sense because this kind of talks about some sort of a input to pituitary. So pituitary is not usually involved in emotional experiences. Emotional experience, though, it's amygdala. Okay. So parasympathetic nervous system to cerebral cortex. Cortex would usually is a larger area, right? So we do not talk about it in terms of emotional alone, even though some aspects of emotions are stored as memories in terms of temporal lobes and areas surrounding hippocampus. So it will not be involved in a threatening situation. It will be most likely amygdala, particularly thalamus to amygdala. Okay. So we know thalamus is the relay center in the brain. So what happens is from lateral geniculate nucleus, information goes to your primary occipital lobe. Okay. So surrounding amygdala also gets information for the person to process any threatening information. If they talked about the person identified it as a threat, maybe you could have talked about the occipital lobe and temporal lobes. But since they said clearly it was not identified, and then he immediately got frightened, so it is thalamus to amygdala. Okay. Right. Cool. Fine. So the wrong statement regarding EEG is that IJKL beta waves occur during alert wake state, which is true, which is what we just discussed. It is true, but it's not the right answer because they're asking the wrong statement. Alpha waves occur when you switch off the light to sleep. I mean, just not because you switch off the light when you're about to fall asleep. Okay, so don't go with the light itself. Alpha waves do occur when you're about to fall asleep. Delta waves occur during awake state. which is false because it is beta waves that occur during awake state, or maybe gamma if you're very highly alert and aroused because of anxiety or things like that. Fine. So theta wave is seen in early sleep, which is also true. So it is beta waves, alpha waves, theta waves which are correctly framed. It is delta waves which is wrong, which is what the question asks you to identify. Okay. So moving on to this, research analysis was done on the previous meanings of newspaper editorial cartoons, which appeared for about 4 years. So this is an example of what type of an analysis or research design. Okay. So it is semiotics. Semiotics basically means meaning of symbols, certain scriptures, and things like that. Hermeneutics is about the analysis of scriptures, not just one script. So like religious scriptures, books, so they can be talking about hermeneutics. Discourse is about spoken content. Okay, so what content was spoken in an interview, you can like analyze it, or a discussion. Ethnography is about cultural studies, so it is semiotics. So because particularly they are verifying the meanings of cartoons which are considered as symbols or drawings. Okay, so it is P. I'm not sure the chat is a bit stuck. Let me just refresh it. So following is true regarding transcranial magnetic stimulation. So TMS, or transcranial magnetic stimulation, is where you use a very heavy coil, pass current through it, so it causes magnetic stimulation current, and that sudden flux of magnet also causes stimulation in circuits, basically the brain cells or axons. Okay, so which is true regarding TMS. It is useful for psychotic disorders and not for depression. It requires general anesthesia. It is given over the occipital cortex. It has no side effects. Ideally, it is stimulation, so we would not try to use it for psychotic disorders, even though there are some, inconsistent evidence. It is actually much more evidential for depression, because in depression you have lower levels of functioning, so you are trying to increase the activity in certain areas, particularly the frontal lobe. Okay, so it requires general anesthesia. It does not require general anesthesia. So this is a false answer, as in wrong option. This is a wrong option. It does not require general anesthesia. So it is ECT and other things that require general anesthesia so that they do not feel it. Okay, so it is safe and can be administered when a person is wide awake. They can speak also during that time. It is given over the occipital cortex, not necessarily, it can be given anywhere. So it has very little side effect. It can make the person nauseous and things like that. So it doesn't mean there is no cognitive, nausea is not a cognitive side effect. No, yeah. So whatever happens is more, less likely to affect a lot of cognitive impairments. If ECT is given, the person is likely to have memory impairments and things like that. So such impairments are not likely to happen in transcranial magnetic stimulation. So this would be the correct answer. It is T. Good. So when a car driver fails to notice a pedestrian who has just stepped onto the road, it is an example of Anton syndrome, amaurosis fugax, inattentional blindness, divided attention. Okay. It is inattentional blindness. It is not Anton syndrome. Anton syndrome is basically a person having cortical blindness but denying that. It's kind of a anosognosia. Okay. Anton syndrome is about cortical blindness. Okay, so some areas of the cortex are damaged, so they will not be able to see. But they still continue to see because there are other parallel areas. So they will deny being not able to see. That is Anton syndrome. Amaurosis fugax is to do with some sort of stroke happening, and then blood vessels near the retina, they get damaged, so it is not getting blood supply, and hence they are blind. It is organic. So it is not because of lack of attention. Divided attention can also be a close answer, but we do not see the pedestrian itself. Okay, so you may have lapses in attention, but not noticing to see a person itself would be inattentional blindness. He's saying the driver fails to notice a person. If you are dividing attention between the pedestrian and the road and things, and you're not able to manage, that is a different thing. That will be divided attention. But not noticing a pedestrian itself is kind of like a blindness. So ideal answer is inattentional blindness. Okay. So which of the following is true regarding suicide? Okay, this is a very interesting question. Let's see if how many are getting it correct. A, B, C, or D. Which of the following is true about suicide? I'm not going to answer this. I'm waiting for the chat. Some people saying C. Okay, you got the right answer. I'm not sure if you know why it is the right answer. Okay, C is the correct answer because we'll go other options wise. So it is prevalent in the general population. Then no, it's actually more prevalent in schizophrenia, because when they come out of schizophrenia, they go through a depressive phase because they're realizing they're getting into touch with reality. So ICD-10 actually had a diagnostic criteria for post-schizophrenic depression. Okay, so this is not likely to be true. Women are more likely to be successful in a suicide attempt. It's actually the other way around. Though women may attempt it more often, men have higher lethality for suicidal attempts. Okay. D is not true because there are scales for assessing suicide risk. So DEX scale is there. There's also a California scale. I'm not sure what is the exact name of it. So lifting of depression may indicate decision to commit suicide. It's not indicate, may precipitate or something like that. So what happens in depression is that the core symptoms are you have pervasive low mood, you have anhedonia, right? And then you have fatigability. Okay, so right now in 11, fatigability is not a core symptom, but in 10 it was. So other auxiliary symptoms include lack of energy, inability to focus, and things like that. So one of the theories of depression is Beck's theory of depression, saying it is not just depression or the severity. If the person has severe hopelessness as a part of his presentation, he or she may have depression. Okay. So when a person is coming out of depression, some things may improve in terms of auxiliary symptoms, like his energy levels may increase, right? Ability to focus, plan things may increase, but the pervasive, low mood and other things may actually still persist. So the person is still feeling hopeless, but they have energy and focus to plan and commit suicide. So that way, it can sometimes precipitate suicidal ideations and decisions to make attempt suicide. Okay, so that is how it may work. One more question. Yeah, they may not be highly reliable, but doesn't mean there are no scales. Okay, so they said there are no scales, which is not true. So is it true that one of the side effects of antidepressants is suicidal tendency? I don't think so. This lifting of depression is not because of that. So I understand why some people may say that antidepressants can cause suicidal tendency. It's not true. So the way antidepressants work is by making more serotonin available, or even if it's MOA and MOA inhibitors, serotonin becomes available again, right? So what happens is the person is able to have more energy. The mood also kind of changes a little bit. But if the suicidal tendency was kind of pre-existing in the personality and they're lacking the coping skills, so that is not something the antidepressants work on. Okay, so if the coping skills were like very poor to begin with, so people who improve on antidepressants and not going to therapy, they may actually still continue to have poor coping skills, and it is actually correlated better with suicidal ideations and committed suicide, successful suicide. Hope that answers the question. So I would say it is not antidepressants which is providing the side effect. It could be the lack of coping skills. not addressed by therapy or something like that. Okay. So next question, the repetition of prolongation of visual phenomenon beyond time of the physiological image is called dash. So even I have not like read about this. Okay. So because I've read fish a few times, I have not come across this. So this I thought this will be a very interesting or difficult option for you to fill. If this question came, even I would have got it wrong. Yeah, it's not in fish. So what is the correct answer? Any idea? Anyone wants to take a guess? No? Akinetopsia. It's not akinetopsia. Akinetopsia is about movement of objects, difficulty tracking movement of objects. Okay, that will be akinetopsia. Paraprosopsia. Prosopsia is to do with facial recognition, like prosopagnosia, right? Proso means facial. So it's palinopsia, but the answer key has given this one, telopsia, which is not true. The answer key is wrong in this case. It's palinopsia. So teleopsia is to do with inability to see farther objects. It's kind of similar to farsightedness, but it's not that. Okay, it's not because of the retinal disparities, or it is not because of the lens, more to do with cortical. Okay, so the right answer is palinopsia. Okay. So next thing, sometimes we are able to read the article and understands content despite there being many misprints. So this is called dash. It's not H. Teleopsia is to do with difficulty seeing longer and farther objects. Okay, or they appear very farther than like shorter objects. So it's to do with distance. Okay, going back to the current question, 28. Wait, so the answer key was not wrong. Okay, law of closure. Huh. So it's based on law of closure. So that will be what? Completion, right? So the logic was correct. So it is based on law of closure. So even though some parts are wrong, you ignore that and then read, complete it and read it. Okay. It is not learned illusion. So learned illusion is kind of like the impact of learning on seeing illusion. You can learn to not see an illusion. You can learn to maybe enhance, which is not likely happening. So if you repeatedly see an illusion, you learn to understand it's not like that. So even Mueller layer illusion, its extent can come down if you are repeatedly exposed to it. Okay, and feedback is given, things like that. So completion illusion is what allows us to complete gaps in or misprints in it. It's not similarity perception. It is not pareidolia. Okay, pareidolia is another phenomenon which is mentioned in fish. So pareidolia is about illusions, but because you have a very fantasizing mind, so you're able to see clouds are on fire, and you will be able to see something like that because of your fantasizing tendencies. You're able to see illusions like that, transformation of the object. So that is pareidolia. Okay, it's not pareidolia. Pareidolia is about as I said, fantasies influencing your perception. So people who are excessively fantasy prone, they could see cloud is moving like a horse. They can see movement in a cloud when there is actually no movement. Okay, so that is the influence of fantasizing on perception. So 29th, Ramu was initially conditioned to be fearful of brown rats. Over time, he began to fear all brown animals. So this is like little Albert experiment. So what is it indicative of? What does this indicate? Stimulus generalization. Okay, so this was pretty straightforward. You guys said it right also. It is not higher order conditioning. Higher order conditioning would mean, so you're associating another neutral stimulus here. So it keeps getting conditioned with another neutral stimulus. Okay, so stimulus dispersion is not what it is. I'm not even sure if that's a term. Stimulus discrimination is about discriminating two different kinds of stimulus. It's the opposite of generalization. Okay, so moving on. In an interview for a post, you are asked who was the first president of India, and you promptly answered Dr. Rajendra Prasad. This is an example of which memory? QRST. Yeah, it is semantic. Okay. Okay, so let me ask you something about the question itself. Did anyone say in your mind of the immediate as a reaction, did anyone say Jawaharlal Nehru? Did anyone think Jawaharlal Nehru? Because I did, and I was like, what is the question? And why is it like weirdly framed? Is that a trick question or something like that? Because I kind of misread president. I hope none of you did. The right answer is semantic though, but did anyone think it is Jawaharlal Nehru should have been there? No. Okay. I guess it was just me. So yeah, 31. Brainstorming is a form of which type of thinking? Divergent thinking. Okay. So convergent means what were we doing here in terms of solving an MCQ? That's an example of convergent thinking. Okay, you converge on one particular option when you have several options. Okay. So non-directed thinking is like in a way divergent thinking, but it is having without any goals. So goals are not there. So that is non-directed thinking. Divergent thinking is kind of goal directed, but you try to get several ways of solving one particular problem. That is what you do in brainstorming. Okay. Heuristic approach is based on your previous experiences and then you finding the most easiest or shortcut sort of a method. So yeah, moving on, you teach students hydroelectricity. You ask a question, due to monsoons, there dangerous level in the Bakra Dam. Formulate a plan to release the water gradually and avoid flooding. What sort of a question is this in terms of Bloom's level, Bloom's taxonomy? So there are 6 levels in Bloom's taxonomy. Okay. So at the very basic level, it is about memory. And then it is about understanding the concept. Then it is about analysis, I think. Yeah, analysis. Okay. So then it's about hypothesis testing. And lastly, it's about creation. I think I may be wrong about the 5th one. Just let me check. So what do you think is the right answer? So 5th one is evaluate, kind of like justifying, critiquing. Okay, so I was wrong in that. That's okay. So what is the right answer? Okay, the terminologies given here are not the exact terminologies. Okay, so by knowledge, I think they are indicating the remembrance. So which is the level 1. Analysis is where you put knowledges in different categories. Okay, so no, that would be the 3rd. Second one is understanding. So you're putting different existing knowledge into different categories and expanding them. Okay, connecting them. So 3rd one is you differentiating. So this is like discrimination. Okay, so you differentiate, compare, and see this has these components. That is how it is different from this. You analyze and compare. Okay, so evaluation is the 5th one. So synthesis is about creation, creating a thing. So the 4th one was application. So this would not be exactly application. You are trying to find a new solution, kind of an application, but application is not given here. So synthesis is likely to be the last one. But anyway, so given these set of options, the answer is synthesis. Okay. So if it were application, it would have been a better fit. Synthesis can indicate the highest level also, which I don't think so is the highest level here, because the highest level is something that you do in your PhD kind of exams, not exams, PhD. So you try to find a new theory, or you try to find a very different new application or things like that. So that would be the highest level. So this is more like application, should not be considered synthesis, but application would have been a better word here. So again, goes on to say the questions are good, but the options could have been like written better. Moving on, it's a 6:30 now. So okay, Thorndike suggested the ability to deal with skilled trades and scientific appliances as a form of dash intelligence. So this is not a very common theory of intelligence that you would read. Thorndike also gave a set of theory of intelligence, and he was against Spearman's unitary model of intelligence. Okay, so any guesses here? He also gave 3 types of intelligence, just like how what is his name? Triarchic. Sternberg gave triarchic theory, so it's kind of like a parallel to that, but this is even before that. Okay, it is G. Okay, so he gave abstract, social, and concrete. Abstract being using verbal intelligence and manipulating numbers, shapes, or things like that, like in your mind. Social is about interpersonal, and concrete is about practical, more or like practical intelligence. Okay, so you having certain skills to do something in the real world using tools and other things. Okay, so that will be scientific appliances and all. So that is concrete intelligence. Okay, so we'll move on to Bronfenbrenner. Also, fluid intelligence is a different thing. It's about Cattell's crystallized versus fluid intelligence. It's not a part of Thorndike's abilities. So yeah, moving on to 34, Bronfenbrenner's ecological systems theory. The workplace of the spouse's workplace, is a part of which system? Micro, meso, exo, macro. It's not meso system. Micro system is your immediate surroundings like family, parents, and all that. Meso system is about external environment and the interaction between immediate surroundings. Okay, so macro is about much larger things. So I think it's exosystem. Oh, if I can check the key. Just a second. Yeah, it is exosystem. So indirect environment of the person, which is not directly, involved, but is also affected and influential. Okay. So macro is the more like culture, or even a bigger thing than workplace and things like that. The culture and the governmental rules, legal system. So those are part of macro system. So exo is kind of like just outside, but not directly related. Meso is the interaction between micro and external surroundings. Micro is your immediate surrounding environment, like family, parents, maybe school also can be involved if it is friends. So those things, yeah, not school. Okay, so the right answer here would be exosystem, which is kind of indirect, but still is influenced or influential. Okay. So yeah, moving on to 35th question. We'll take a break soon, maybe. We just have 15 more questions. So in conflict management, the approach that engenders a losing-losing, a lose-lose situation is called dash. It's definitely not collaborating. Okay. Yeah, it's compromising, because both of you have to compromise on it so that both of you don't cause anything. It'll be accommodating if you let the other person win and you lose. Competing is where you try to win and we make the other person lose. So okay, sorry, these are wrong. Collaborating is where both of you try to win together. Okay, so compromising is, okay, let him also lose, let me also lose. So that's compromising. Okay, so the personality of a person. Moving on, if you have any doubts or questions, you can ask. We'll stop with 40. Okay, and then take a brief break and come back. So the personality of a person who exhibits extreme black and white thinking and has instability in relationships is likely to have which of the following personality disorders? Is it Q, R, S, or T? It is not paranoid. In paranoid, they do suspect a lot. So you may say black and white cognitive error is there. That's likely. But here, this black and white is more likely to indicate splitting, which is a psychodynamic defense mechanism. Okay, so which is characteristic of borderline. So they also have instability in relationships, black and white thinking. They split people as either extremely good, extremely bad. So that is the kind of black and white which is meant here. I understand your logic, like they may use black and white, things. There also, this person is either suspicious or not suspicious, may happen. That can also possibly lead to instability in relationships, but it is especially more characteristic in borderline. But more characteristic of paranoid would be being suspicious, okay, and holding grudges for a very long time, okay, and not forgiving people. So histrionic is about excessive flashiness, selectivity, and then doing whatever these surroundings are doing, not having a set of like their own standards, okay. So avoidant personality is about kind of very similar to social anxiety disorder, but here they also feel that they are inferior than most people, and people will criticize them and judge them as a result. So they avoid interactions. So that is avoidant. So right answer here is borderline. Okay. So other borderline characteristics involve unstable sense of self and high impulsivity. Okay. So other things like self-harm tendencies and what else could you say? Emptiness, sense of emptiness. So these are all some core symptoms of borderline, and particularly instability in interpersonal relationships. Okay. Yeah, histrionic is attention seeking. So yeah, next one, on the basis of Alport's trait theory of personality, a rich person who gives away all his property to society is exhibiting which level of personality trait? So these three are given by Alport. This is not likely to be his thing. Is it cardinal, central, or secondary? Yeah, yeah, it is cardinal. So the very core is the cardinal thing. So they consider other things also core, more stable, but not as core is central. So here the person giving away the property is about a very core moral value, right? So that is more likely to be cardinal. So other things like he's honest and he's usually joyful, go lucky, which are more stable but can also change, which will, like not likely. Cardinal is something which will not differ no matter what. So this person has a very high core value and is giving away property to society. He'll possibly likely to do that in most situations. So given that logic, we go with cardinal. Central is like still core, relatively stable traits, like joyful, but people do also get angry, right? So that will be more likely to be put under central. And secondary are like very trivial preferences. The person likes salad more than non-veg, something like that. So temperamental traits are more about ingrained traits that are when a person is born, more biological. So that has nothing to do with Alport. So it is cardinal. Okay. So two more questions and we'll take a break. Emphasis should be on, okay, so what am I reading? The following statement is true regarding isolated adjustment disorder. I'll tell you about adjustment disorder. It's there in IC 10 also, 11 also. So an adjustment disorder, it's usually after a stressor, and the person's symptomatology does not meet the criteria of a PTSD or a depressive episode. Okay, so it is not as severe as a depressive episode, and also not as traumatic as a PTSD disorder. Okay, so what should be true here? Should emphasis be given on strengthening coping mechanisms? Be in-depth psychotherapy? SSRIs needed for a long period? Sedatives do not give relief? It's A, right? So the person is having adjustment disorders because of a stressor, ongoing or just happened. Stressors could mean like loss, or loss of job, loss of a relationship, death of someone, bereavement, something like that. So this is not the same as prolonged grief reaction, but it's more to do with a very generic source of stressors. So what you should do is work on their coping mechanisms. This is true. They do not need in-depth psychotherapy. So it is not like some childhood attachment issues coming through, possibly present, we don't know, but it is generally not required. SSRIs are needed, but not for many months. Excuse me. So they may benefit from SSRIs also because to uplift their mood, they may have some non-pervasive low mood also. So this can help. Sedatives do not provide relief in acute phase. So they may have a lot of sleeplessness and things. Sedatives do help, especially in the acute phase, immediately after the stressor. So this is wrong, and these are also wrong. And A is the correct answer. Okay. So just two more questions and a short break. The neurotic defense mechanism by which a person who cheats on his income tax return, but also at the same time criticizes the government for corruption, is which defense mechanism? Not likely projection. He kind of does agree that, I mean, not agreeing, he does realize that he's cheating on his own income tax return, but at the same time criticizing the government for being very corrupt. So this is not something that Freud or Anna Freud had given. So the right answer here is compartmentalization. I'll tell you beforehand because it's a very difficult one. So this is not a defense mechanism given by Freud or let's say Anna Freud. So you'll find these in the appendix sections of DSM-4, DSM-5, or even in fish, if you can find. I'm not sure about fish though, but APA has given another set of defense mechanisms for therapy. So you'll find it there. Okay. So it is not displacement because he's not displacing his anger onto someone. Definitely not dissociation. Seems very close to projection, but it is more of compartmentalization. It's basically like in an argument with your partner, you say, oh, that situation is different, even though there are similarities. You're compartmentalizing something else into a different category, but a similar response is acceptable in a different category. So that is compartmentalization. In a way, kind of like rationalization, you could say. But it is not like he's denying he has no problem. It is only the government who is making this mess. But he is also in his income tax return, he is cheating. It is okay to do that in his own private life, but as a public, the government is wrong. So I understand why you're saying projection, but it is not very ideal of projection. And of course, I understand compartmentalization is not a defense mechanism you may have come across with. Okay, so the right answer is compartmentalization. So a mature defense mechanism, okay, where a painter who has obsessive sexual ideas redirects them into his paintings. This is very simple. Sublimation. Okay, so there are neurotic defenses, and there's something in between, and there's mature defense mechanisms also. Okay. So it is sublimation. So we'll take a break here just for 5 minutes, and we'll come back by 45, and we'll finish the remaining 10. Okay, so they're like pretty simple, so we should be able to do that. All right. hope you're back from the break. I mean, I needed a very short break now. So yeah. Anyway, we just have 10 more questions. We'll kind of rush through them. And if there are any doubts or questions at the end, we can have a small discussion there. Okay. So in case of PTSD, so moving on to the next question real quick. In case of PTSD, diagnosis is made, and what is proof after the diagnosis is made, and for management, which of the following is true regarding management? So what does a person with PTSD require after the diagnosis? Anyone wants to take a guess? Put it in the chat. Nature of psychotherapy, that's one possibility. What else? N, cognitive processing therapy, good. So it's not like other options are wrong. So almost every option is partially. Okay, so which is the most correct answer that is we're supposed to figure out here. Okay, so I understand prolonged psychotherapy may be required, particularly if the intensity is very high and they are avoiding a lot of things. Okay, but it is cognitive processing therapy which is most useful in this case, because the way we conceptualize PTSD, the traumatic memory is split and it is defragmented. So it is almost as if it is occurring right here in the present and in this physical space. So they are not able to distinguish between what is reality and how it is right now. Okay, so it can be to that extent also. So cognitive processing is about narrative exposure therapy, which is even shorter. So that is also one way of saying that it may not be prolonged. Okay, so in narrative exposure therapy, what we do is we have a lifeline and we talk about stones and flowers, stones being the traumatic events and flowers being good events. So what we basically do is we attach the hot cognitions, basically these flashbacks and the emotions attached to them with normal contextual information. Okay, the day I was walking, I was going on the road and things like that, so that the fragmented memory is associated in time and that space. So because of association, that is one way. Okay, so narrative exposure therapy kind of works on this way. Clonazepam may be useful if a person is having a lot of issues, but is generally avoided. Person has dissociative tendencies. Even relaxation can be contraindicative in PTSD, especially they are prone to fainting and things like that, because that can trigger the parasympathetic nervous system to take over and then to faint. So it can be contraindicative. But if the person is only having arousal symptoms, maybe it can be used. But then again, it would be like avoidance. So avoidance is a major symptom in PTSD, which we are supposed to work on. So clonazepam may be contraindicated in most cases, except in very high cases of physiological arousal. Thought stopping though definitely does not work. So it's a very, you could say, useless sort of a technique. Okay, so just like it's useless in OCD or even contraindicated in OCD, we'll consider this is something that does not work at all. Okay, so correct answer would be cognitive processing therapy. They'll have to process the hot cognition, which is the memory, emotions associated with the event, and have to connect it with the proper time and place through either narrative ways or through different ways. There are various ways for trauma processing. Okay. So yeah, any doubts in that? Okay. Okay, so we'll move on to the next question. The following is true regarding management of GAD. Okay, antidepressants are more useful than benzodiazepines. ERP is very useful. Emotive imagery is not useful. Deep brain stimulation is effective. Which would be the right answer? I would say ERP would not be very useful in GAD because you don't have a particular specific stimulus that you're scared of. Okay, so there's a wide range of feared consequences. So how will you even put them into hierarchy and do ERP? Response inhibition, though, yeah, it has to be done. It is kind of logical, but how will you construct it? So there's a lot of challenges in that. Okay. So deep brain stimulation is not necessarily for Parkinson's, but for other subcortical things. So we may not be using there. Even treatment-resistant depression can be treated with deep brain stimulation. So not necessarily only for Parkinson's, but for GAD is not indicated. Okay. So emotive imagery may actually be useful in this case. So it's an REBT technique, so where they can use it. But antidepressants are usually more likely to be prescribed in GAD, like SSRIs and tricyclic, than benzodiazepines. So they become benzodiazepines are kind of like sedatives. So they reduce, arousal and things like that. So in GAD, the conceptualization is that if you talk about metacognitive or any other conceptualization, they have excessive worry and they have positive role of worry. So thinking that worrying is good. And also at a later time, they feel like, oh, worrying is taking away negative perception of worry. Also does happen. Okay, so that is a meta worry. They worry about worrying. If I don't worry, something may happen, right? So it is most likely a sort of a rumination that is happening there. So antidepressants can also be helpful in this case, more than benzodiazepines, because even if they are sort of calmer, they can still keep worrying. Worrying is the most predominant symptom here, which is very similar to rumination and depression. Okay. So anyway, it's Q. So we'll mark that and move on. In a patient with OCD, the psychological cognitive behavior therapy approach is wait, psychological cognitive behavior therapy approach. There's no ERP mentioned here. I actually didn't proofread this question, but none of these options are ideal gold standard question. Okay, so you guys give me your answers. We'll see. I just find out which is this exact question number and find out its answer key, because none of the options are the ideal ones. So ideal one would be ERP. ERP would be the most apt thing. Okay. Definitely not thought stopping with a patient. It'll be contraindicated. They also try thought suppression and it backfires. That is why obsessions become even more frequent and unmanageable. They become even more important. Okay, so it is not supposed to be that. It's also not supposed to be relaxation, because whatever you teach as relaxation has a tendency to become a compulsion. Okay, so basically the neutralizing behaviors are working by negative reinforcement. If you do relaxation, they'll try that more ritualistically, and that can become a compulsion too. So that is also contraindicated. Let me just get the questions. 1 second. So per se, emotive imagery is more of an REBT technique. So let me just get the correct answer based on the key itself. Okay. Just a second. My laptop is a bit slow. All right, we'll come back to that while it loads. Even this, using another imagery instead of thought, can become vocational technique here. But if you go with history, historically, thought stopping was earlier used, but it is contraindicated. Okay, it does not work. It actually makes OCD worse. So if the answer key is that, then it's so bad. It takes so long to load. Anyway, fine. It is could be thought stopping according to the answer key. We'll come back to that. So development of new onset diabetes is most likely because of the atypical antipsychotic dash, clozapine, lurasidone, aripiprazole, and ziprasidone. So I'm not sure if you have like known or have any exposure to it. It is clozapine. Okay, so clozapine, olanzapine, so they have kind of this tendency to increase rapid weight gain by causing like temporary onset diabetes mellitus when the drugs are taken away, so they do return back to baseline also. But they do need those drugs because that is what they're responding to. So clozapine is the right answer here. I understand if it is difficult for you that you may not have the exposure here. The correct statement regarding primordial prevention is A, B, C, or D. 45. Even if they have anxiety with OCD, relaxation is supposed to not be used. So they're supposed to learn to deal with the anxiety. I'll come back to that again. Just saw the chat and responded. So here it aims to prevent the risk factors itself. Okay. So if you look at the various levels of prevention, so you have primary, secondary, and tertiary. Okay. So primary is about not getting the illness. So you do things so that you don't get the illness, but you may have the risk factor. Okay. So secondary is about you got the illness, so you're trying to undo it. So it's kind of like the earlier phases of illness. So it is just like first stage of cancer. Okay. And then you're trying to cure them of cancer. So from being in an illness to stepping out of that illness. So tertiary, I'm not going to say cancer here because people do die of cancer. So I'll say some other chronic illness like Parkinson's. And the person has Parkinson's already. But instead of curing them, which is kind of not possible, you kind of slow down the deterioration. You kind of try to increase the quality of life, or you make the symptoms less worse, or things like that. So even beyond this, so understand that in primary, you're not addressing the risk factors. So risk factors are not addressed. But in primordial prevention, in a community level or something, so the risk factors are also taken away. So it is option A, aims to prevent the development of risk factors. B is also kind of okay, but it is more in line with primary. You kind of modifying existing risk factors so that the disease does not occur. That is typically primary prevention. Okay. Susceptible population is also kind of primary prevention. Symptomatic patient depends on the extent of disease, can be secondary or tertiary. All right, fine. So test designed to assess ability to predict future performance is definitely not this. We're talking about ability, even though personality can be used for predicting, but for performance, we're talking about ability-based trait. So personality is a non-ability-based trait. So A, B, C, D. Okay, so yeah, recording, I'll even if it stops, we can change it. Right. It is B, aptitude test. Achievement test is about past, how much you've learned. Intelligence is more generic, is about innate abilities, not specific about one particular area of performance. Okay. So Carl Jung classified personality based on certain characteristics. Sorry. One of them is this. It's not picnic, it's not mesomorphic, it's not phlegmatic, because these are based on Sheldon's criteria. This is based on another person who talked about, again, body types. This is a humor, like phlegmatic, what are the other humors, bile and things like that, right? So Carl Jung talked about functions and attitudes. He talked about 4 functions, 2 attitudes. Attitudes being extraversion and introversion. So ambiversion is kind of like this combination. That's what they meant. It's not exactly what Carl Jung had said, but it's fine. Okay. So other things like intuition, what are the other things? Let me get this. Reasoning, INTJ. Okay, judging is there. Sensing is there. Okay, it's sensing versus intuition. Perceiving. Sorry about my handwriting. So what are the various functions are that? You have intuition versus sensing, perceiving versus judging as functions. So attitudes also get, attached with them. So that is how you get 16 different personality types, which is the basis for MBTI. Okay. So ambivert is something close, even though it is not the exact word. You can consider it's a combination of extroversion plus introversion. The other things are not true. Okay. So I'll be quick here. Not sure if the recording has stopped. Let me see. It's not stopped. Histrionic personality could have the following clinical features. Okay. So this should be easy. Superstitious, no, that would be for schizotypal. Okay. Suicidal tendencies can be for borderline, not the key criteria, but should be there. So it is actually seductiveness, attention seeking. They do so to get attention. So being shy can be for avoidant, anxious avoidant. Seductiveness is for histrionic. Okay. So last 2, the traditional scientific approach to understand everyday life experience of people. Histrionic need not be having suicidal tendencies. Okay, if someone said B also, that is more characters of borderline. But anyway, here if it's B and C, they are similar, but it is most to do with B. Excuse me. Okay. So anthropological is about a particular culture. Ethnographic is also more related to a cultural phenomenon. So they didn't say life experience of a particular culture, but any person. Okay. So that is phenomenological. So it is about lived experiences of a person. It is about a phenomenon that occurs. Like, let's take, for example, hallucination is a phenomenon. Okay. By exploring how hallucination is felt, their lived experiences with hallucinations, we are talking about phenomenological approach. It is not cultural based. So it is not A or C. Ecological is something else entirely. It's not about the lived experiences. Okay. So it'll be B. So lastly, you're playing cards and someone somehow which card is going to be dealt next, and it turns out to be accurate. So what ESP are you displaying here? Telepathy, clairvoyance, psychokinesis, pattern recognition. Clairvoyance is literally the term for future telling. Yeah. Telepathy is communicating through mind. Psychokinesis is moving things with mind, like people bending spoon and things like that. Pattern recognition is though not an ESP, it is more of a cognitive function. Okay, so that is it. I understand, like, if you have been scoring, you can put up your scores in the chat box. Okay. Okay, so the question has loaded. So let me see which question was this OCD thing. Okay, 98, is it? Okay, let me see. Oh my God. So for 98, the OCD thing, they've actually given thought stopping. So even though I understand behavior therapy has been asking thought stopping as a thing, it is contraindicated. So please do not think that you can do thought stopping with a patient with OCD and it will work. It will actually make the obsessions even stronger. Okay. So what works in OCD is that because it is a repetitive, intrusive thought, you'll have to get used to it. When you do get used to it, give up control on trying to change the obsessions, you may notice them much lesser, which is what they metacognitively called as the cognitive attention syndrome. Okay. You keep noticing obsessions because you give it importance and keep reacting to it. It becomes the most important thing. You keep giving it attention. So thought stopping, you again give it importance and address it, right? So that is again a contraindication. So cognitive behavior therapy, at least the recent ones, the most research evidence-based ones, advise against thought stopping. Even relaxation, they advise against. But sometimes if the person's anxiety is way over the peak, they may use it as a adjunct. Very rarely, but ideally it is contraindicated. Okay. So occasional rehabilitation, though it's not related at all. Imagery can also be contraindicated, so it can become a compulsion too. So we do not do that in OCD. So, but the answer key says it's thought stopping. So because so if you were to rate this question paper, it was actually really good. A thought stopping will not work, so please don't use it also. Okay, so you will be grilled by your consultant psychologist for your use of thought stopping. But yeah, maybe people who are not used to clinical psychology may do it because they do not know exactly the contraindications and all. They have read about it and tried to use it. But as a clinical psychologist, if someone is using thought stopping, then it's a indicator that they have not done their course really well, I would say. Not to put the blame on anyone, but just saying. Anyway, what was I about to say? Yeah. The whole paper was really good in terms of the questions. So I would say it was more application oriented than IBHAS. And it was actually very interesting also to answer than IBHAS questions. But the thing is, sometimes the options that they kept are not so great. Sometimes two options seem to be right. Sometimes in the thought stopping example, no, none of them seem to be right. So the options though could have been done much better. So that is my verdict. So was anyone calculating these total scores or something like that? Were you able to get more than 45 at least? So 45 would have been a good mark, benchmark. Even 40 would have been a good benchmark, but would say a lot of improvement would be there. If you did get 45, then definitely does mean that you can get into the institute, possibly. That's what I'm guessing. Oh, 2023 cutoff was 85. Good. So these are particularly the more difficult questions. Okay, so GMCH did have 100 questions, and I took only the most difficult ones and application-based ones. So the more easy ones, just based on memory, I just didn't use it for this particular thing. So if you did get at least around 40 to 45, then you can consider yourself like, good enough to get in there. Okay, kudos, congratulations for you. Anyway, so we'll stop here, but if you have any doubts or questions, we can have a small discussion. We do have the time. I mean, we don't have the time, but could be some 10-minute discussion or so. Guys want, you can unmute and speak also. That's fine. I can stop the recording if you want. Just for the discussion part.